Hello, and thank you for listening to the podcast, The Power of True Stories. My name is Vanja Banovic, and I am going to be your host. And today we are going to try to answer the most common question that all of us who went through IVF cycles ask a lot. I have asked this question many times, and I am absolutely sure that all of you who have gone at least once through failed IVF cycles have asked this question, and that is why I am not pregnant, why my IVF cycle has failed. Most of the time, when we women ask this question to our doctor, they don't really give us a clear and straightforward answer. I mean, I understand that they cannot know for sure what the reason is, but my guest today, Maja Henigman, will try to give us the closest possible answer to this very important question for all of us who are on our way to motherhood. Of course, we will talk about some other very important topics. We will touch base on one very interesting research that she has done in the past. But moreover, she will just give us a general feedback about how we can go through IVF a little bit easier and a little bit more confidence. Our guest, not only that she is an IVF coordinator of one fertility clinic in Czech Republic, she is a member of ESHRE, which we are going to talk about and clarify what that is a little bit later. But more importantly, she is a mom of two beautiful boys who were conceived with the help of IVF. Dear Maja, welcome to the podcast.
Thank you, Vanya. Thank you for having me.
Let's start from the beginning of your journey. You were quite young. You were just 25, if I remember well, when you were first time advised that in order for you to have babies, you have to go through IVF. Can you please take us back to that period and tell us what was the reason for that advice from the doctor?
Yeah, sure. Actually, I was 24.
That's really young.
Yeah. I had my first child when I was 25. It was very interesting, actually. I basically just switched my gynecologist, and I had just a routine checkup. It was like a gynecological exam and an ultrasound because I did have some kind of pains that I wasn't sure about. And the doctor saw there was quite a large uterine septum. This is nothing special. It's not like threatening, or it's not necessarily even a problem for getting pregnant.
I need to interrupt you immediately so I don't forget. Can you please quickly clarify what is uterine septum for ladies who are listening?
It's basically something that you are born with. It's a remainder, a part of when the fallopian tubes and the ovaries, they separate, but the uterus must come to become one organ. And the septum is sometimes the reason that it didn't fuse properly. Something was left behind, and it's there. It shouldn't be there, but it just remains. And a lot of women have uterine septums. They can be very large and they can be very small, but it's not something that you should be very worried about. But still, my doctor saw it and he recommended to have it removed just because, why not? So I had the, let's say, hysteroscopy. It was removed, everything was fine. And the doctor told me to, try for a baby for 1 year because I was young and it was just advised, maybe now you will get pregnant and maybe we will see what happens. And we did that, and it was over a year. I still wasn't pregnant. We didn't understand what was going on. I thought that maybe there's something wrong with me. Maybe I'm not ovulating as I should be or something like that. And I came back, and the doctor said, I don't think there's anything wrong with you. So let's just check the partner and see if there's any issues there. So
Mm-hmm.
he had a spermiogram done, and the results were catastrophic. So they were so bad that they actually not advised us, they warned us that maybe it won't be successful with his sperm, that maybe we will have to consider sperm donation. But
Mm-hmm.
I am young, we need to try, we will see what happens. So, this was the main reason why we maybe started with fertility treatments that early,
Mm-hmm.
because we discovered this issue
Mm-hmm.
and we knew that we wanted to have a family. We were together for a long time.
Yeah.
So it was like a normal step for us. And in our case, this was very, very good because my age was the determining factor why we did get pregnant on the very first IVF, the very first transfer.
And because the problem was male infertility, how did you both cope with that realization? How did you feel about it? And especially your husband. We know how men can really cope badly with that kind of information.
Yeah. Uh, I can't I can't say for sure because he maybe didn't tell me some of his emotions or thoughts, but he understood what the issue was, and we did have a discussion of possibly using donated sperm if needed, and he was on board with that. He did agree. He said that he wants to have a family with me, and if that would mean to use donated sperm, then that's what we would do. So
Yeah.
he was very open to that. Of course, thankfully we didn't have to use it, but I'm sure at some point he didn't really feel good about himself because
Yeah,
it is like an ego factor
for
with
sure.
men more than with
Yes.
women. For me, I was just happy that we found the issue because it's very hard when you are facing infertility but don't know what the issue is.
That.
In my experience, people that have unexplained infertility are the ones that maybe suffer the most because you
Mm-hmm.
just don't know what's going on. So I was happy we did get a diagnosis.
Yeah, good that you mentioned that. So at the beginning, I did not mention the most important thing, and that you are a nurse. And as
Yes.
I mentioned, you are a member of ESHRE. Please tell us what it is, and you are nurse in which sector. This is very important.
Yes. So in Slovenia, we have, let's say, basic nursing, and that's like a high school education. And then we have a higher degree where you need a diploma.
Mm-hmm.
So I have a diploma. Let's say in English terms, I'm a registered nurse. In Slovenia, it's like a special term when you say like you're with a degree. So it might not
Yeah.
sound the same in English. Now the it's an issue because we don't really have specializations like when you have like a doctor that's like specialized for reproductive medicine, or you
Mm-hmm.
have a doctor that's a cardiologist. This is not actually possible for nurses in Slovenia yet.
Mm-hmm.
We do acquire specialized knowledge, but it's not like a special profession. You're just a nurse.
Yeah.
Then you gain this knowledge by actually just working in a field and, let's say, going to seminars and educating yourself. So it was very important for me to become a member of ESHRE because it's the reason why I want to do all this. It's something that really interests me, and if you are a member, then you are, let's say, in the know. So you have all the new information from the field of reproductive, let's say, medicine. And I really like to be involved in any, let's say, webinars, any campus trainings, anything like that. So what it is, it's the largest organization in Europe.
Mm-hmm.
It basically stands for European Association for Reproductive Medicine and Embryology. So it's like it encompasses everyone in Europe because
Mm-hmm.
you could have separate associations within the countries, but this is like a European association that covers everything. So it's important for me to be a part of that because I think that you just need to keep evolving and discovering more knowledge if you really want to grow as a person, and especially in medicine.
As a part of your growth, you conducted in Slovenia, right?
Yes.
One very important research that more than 1,000 couples who are struggling to become a parents took a part of. Please, can you tell us what was the research about and a little bit about your findings?
Yes. So uh, when I was finishing and getting my diploma, I wanted to do something meaningful with it because, of course, you can finish it with something basic like literature overview and you're done.
Yeah.
But I wanted to do something important, something that would make perhaps a difference, something that would, even bring me to be more involved because I knew that this was possible for me to do since I'm administrating or I'm like the head of the largest patient association. Like we have like a group on Facebook with more than 4,000 members. And I knew that I have access to these women, mostly women, of course.
Yeah, yeah.
They're most involved. And I wanted to do something to kind of see where we are at, because it doesn't matter that I work with a foreign clinic. I still live in Slovenia and I still want that Slovenia is like offering the best possible treatments to its patients. So
Mm-hmm.
I did a study to basically find out patient satisfaction with IVF treatment. So it
In
doesn't mean
Slovenia.
in Slovenia, specifically in Slovenia,
Mm-hmm.
it doesn't mean that I was trying to figure out whether they are happy or sad, because, of course, if it's positive, you're happy. If it's negative, you're sad. I was trying to find out where are the shortages of our system, because it's public health system. It's not private. We don't basically have any private IVF clinics in Slovenia. So
Mm-hmm.
I wanted to see where is the room for improvement and where are we really good. And mostly, women showed that they were very happy with the medical part. So there wasn't any issues with, let's say, IVF protocols or stimulation or egg retrieval or anything like that. That wasn't the issue. The issue was psychological support, informational support, um, a better connection and understanding between doctors and patients. And what stood out was that they were mostly happy or satisfied with nurses, but
Mm-hmm.
not doctors. Because nurses are the ones that take more time and they, discuss things with the patient when they maybe have like a negative test or something like that.
Yeah.
And the doctors simply don't have enough time for the patient. It's not like necessarily their attitude,
Yeah.
but it's just the lack of time. The lack of
Mm-hmm.
time, they don't get enough of, let's say, they don't have enough time to talk about serious issues or anything like that. They just, okay, we failed, let's continue with treatment. So,
Yeah.
we will see what happens. Good luck. And that was the main issue.
To be honest, Maya, now when I'm listening that, I feel that in every country, if you do the research, the
You will get
result will be
similar answers.
yeah,
No.
similar answer. I mean, since I started this podcast, these are actually the comments that I hear from all the women who went through cycles, like that there is not enough support, psychological, emotional, that they feel that they are like 10 minutes and then next patient goes in, the doctors don't have time for them. Everybody feel that this connection is like very cold, if I may say like that.
Yeah.
So when you got all the results, did you do anything, or was that maybe initiator for you to go into that field and to become IVF coordinator, or there was something else?
No. Actually, it was the other way around, because I was
Uh-huh.
already involved in the field even before I got my degree or diploma.
Mm-hmm.
So this was maybe just a step forward in kind of cementing, yes, maybe my approach to patient care,
Yeah.
even though I already knew what patients wanted and needed, but this was like a confirmation that they really need someone like myself or anyone else, basically, that steps in the role of providing maybe not necessarily psychological support, because we don't want to confuse people that you can get psychological support from, let's say, a coordinator, a
Yeah,
nurse,
yeah.
because they do need still a psychologist, a therapist, and all of that. But still, you do offer a lot of support if you offer enough information at the right time, and if you know how to explain things in a way that people can understand. And this
Mm-hmm.
is what they usually want and really, really desire, but can't have from doctors, because they sometimes believe that if you are not a medical professional, you are not capable of understanding certain things, which is not
Yeah.
true. If you are very good at what you do, if you are truly a specialist in your field, then you are able to explain what you do and what's going on even to a child. So I don't
Mm-hmm.
accept that when doctors say like, well, you would have to have like a medical degree to understand this. It's not true. You
Yeah.
just need to have time and patience and just try to explain everything in a way that the couple will understand. And then they can find a way to continue treatment even if they are unsuccessful.
So you said you had two IVF treatments. So the second time was again successful from the first attempt, right? No?
Nope. Nope.
Oh, okay. Tell
So
us.
we got very lucky on our first IVF, and this was maybe an issue for me because in my mind, I thought that, okay, so we can get pregnant naturally, but with IVF, we got pregnant right away. So all we need is IVF.
Yeah, no
And
problem.
when
Yeah.
yeah. And when we decided to have the second child, the first one was 15 months old because I had a cesarean section, so we had to wait a bit
Yeah.
longer. I was right back at the clinic, ready to go. Like, yes, I want them to be close in age. Let's go. Let's have another one. We had one frozen embryo still from the first cycle, and we transferred that. And I was just positive that it's gonna
Yeah.
be a like a pregnancy, and it was not.
Wow.
And I was confused, but I tried to explain to myself, well, maybe that embryo just didn't work out. So we did another cycle of IVF with very poor results. Very poor results. We got one embryo that was questionable and it was negative again. And we had to go for another
Wow.
stimulation. And all of embryos failed. So there was no transfer at all. This was the most painful cycle that I remember
Mm-hmm.
because I came to the transfer all happy, let's have this child, and then no embryos for transfer. And then the last cycle, we supposedly had a better result. On the third day after my egg retrieval, we had 4 embryos and they were looking really good. Like, wow, 10 cells, like, wow, pretty. Let's
Yeah.
just transfer one. And I wasn't really happy because they were maybe. I didn't like the fact that they wanted to transfer on day 3 because on day 3 you really don't know what's going to happen to these embryos. But we did the transfer and it was negative again. And from those 3 remaining, only one survived to be frozen. And I was really starting to believe that, well, we had like huge luck with the first one. We're going to have like one child and that's going to be it. But then we decided to just transfer the last one and see what happens. And that was the second child.
So when you had these all failed cycles in between, were you asking yourself or your doctor why? Why didn't happen?
uh, yes and no. I kind of knew what was going on because of the very poor embryo development. So
Mm-hmm.
I wasn't looking at myself and trying to find issues in myself. I knew that I can get pregnant. I did, and I did give birth to a healthy boy. So that was not an issue. I was starting to doubt if it's possible to get a healthy embryo anymore, because they were simply not developing properly. They
Yeah.
were either stopping, or they were some other issues were happening. So I was trying to understand, why is it not possible to get another healthy embryo.
Yeah.
uh, with regards to my doctor, I was just suggesting to try different protocols and different medication, because I knew that I would need to get more egg cells to potentially get some more embryos, because we knew that the sperm quality was really bad, but I also didn't get a lot of cells. I got like 5, 6, 7 cells, and I knew that I would need to have like 10 plus to
Yeah.
get a better result. So I was just trying to get like a better protocol, something different. And thankfully, my doctor was very open, and she did try basically everything to increase the chances. And maybe it did help at the last cycle that we did change some things, and I did get maybe 1, 2 eggs more. And we did get the embryo that was the second child. But still,
Mm-hmm.
it was a very long journey in my
Yeah.
mind.
Yeah.
Now that I look back, they're just 4 years apart. So, like, the first one is 10 years old and the second one is 6. It's not a big deal, but at that point, I was getting really frustrated. I
Of
was
course.
getting really, like, I remember I was sitting in my bed crying. Why am I not able to get pregnant again? I know
Yeah.
I can. Why am I not getting pregnant again? And it was very hard to start all over again. Each time another stimulation,
Of course.
another stimulation, another egg retrieval. Maybe
Yeah.
it's easier when you have a lot of embryos and you can go through these cycles, but when you have like egg retrievals, egg retrievals, egg retrievals, it's not nice. So,
Yeah.
yeah.
So tell me all these experiences. Now, if I count, it was like 6. If I counted well,
It was a lot, yeah.
it was a
It
lot.
was at least, let's say, 5 stimulations, I believe, in total.
Okay. So all these experiences, are these experiences also one of the reasons why you've decided to be, let's say, advisor to couple who are struggling with the same issue to become a parent? Do you feel that you are maybe more empathetic towards couples?
I think this is a huge part in my work, because I understand the frustration, and
Yeah,
I understand how hard it is to find the will to continue when all you see is negative tests.
yeah,
And yes, I think that this is a large part why patients, let's say, enjoy my work and everything that I do more than if some IVF coordinator is typing an email somewhere, or if the doctor just says, well, let's try again, or something like
yeah,
that. Because I understand, I know what I would like to hear. Because if I were back in the role of an IVF patient, I know what I would like someone to say to me. And I always try to be very honest and direct with my communication, because sometimes people tend to be very optimistic, or they try to pick up the people, like, that are
yeah,
struggling with infertility. Don't worry, it's gonna happen. Don't worry, just
yeah,
relax. Maybe take a short vacation, forget about it. I'm sure you're gonna get pregnant. And I really don't like using those words,
yeah,
because it creates a false hope,
yeah,
and these people don't want to hear that anymore. They're sick
yeah.
of it. They don't want to hear
Yes,
it.
it's so true. Yes. So tell us what exactly that you do. So let's say I know you and I know
Yes.
what you do, but
Mm.
please tell to our listeners. So you are basically, if I and my partner want to have an idea about what we're supposed to do, we
Mhm.
get in touch with you. And then how do you start? What do you ask? What do you recommend? Maybe some supplements, food, special diet. Do you check maybe their results from before? Just like give us an overview on what do you do before couple goes to actual procedure.
Yes. So all of the mentioned. So at first, I really want the couple to give me all the information, everything they can think of. So how long they have been trying to conceive, was there any pregnancy before, even with a previous partner, what kind of treatment was done, how many treatments, what kind of embryo development, was there any kind of missed abortion, biochemical pregnancy, is there anything in the family, is the woman suffering from some kind of chronic illness, or maybe the man, or anything like that. So I take like a complete medical history
Yeah.
before I can even comment on what can or can't be done. So maybe this is the most important part,
Mm-hmm.
because I usually have like an hour or an hour and a half discussion with the couple to go through all of this. And
You
this
go
is
this
some
to do this online, right?
yes, let's
Okay.
say via Teams or Zoom or whatever.
Yeah.
So I really take the time and I want to go through everything. So it doesn't matter how long it takes. Tell me everything you think it's important. Because when you come to the doctor, yes, of course they have your, let's say, results, but they have those, let's say, 15 minutes for you. And that's not enough time to find something very important that might be missed. So we really need to take the time to go through everything, the whole documentation.
Yeah.
Yeah. Then I wait. I don't let's say just give a diagnosis. I'm not allowed to actually give a diagnosis, but I don't go ahead with let's do this. I
Yeah.
wait to see what the couple actually wants and what the couple is thinking about, or let's say if there is something they are not willing to do. So
Mm-hmm.
if there's like an issue, I can maybe see right away that the couple needs egg donation, for example. I
Yeah.
can see it straight away. Only egg donation will bring them success.
Mm-hmm.
But if they tell me in advance, sorry, we can't accept egg donation, we just want to try with our own egg cells, then I know that I won't lead that discussion in that way. I will still be honest. I will still explain that it's probably not likely they will succeed, but we will try to help them in any way possible with maybe trying to get pregnant naturally if that's an option or something like that. So I always wait to see whether the couple is open for other alternatives before even suggesting them. And I always ask them if I can be very honest or if they want maybe a milder version of what I have to say.
I can
Because,
confirm that you are very straightforward, and which is
yes,
really great, to be honest.
yeah,
It is more fair to the couples.
I think in the longer run, people appreciate it, but they don't like hearing it, especially for the first time, because
Yeah.
you sometimes have to explain some things that are very hard to hear. So but yes, then we go through any questions they have, any
Mm-hmm.
questions. It doesn't matter how many questions, just go ask straight ahead, and
Yeah.
I try to answer all of them if I can. If I can't, maybe that means that we need to order some tests or some examinations, or in any case, I usually advise some extra results, because in Slovenia, there is an issue also when the couple starts with IVF treatment. They usually never repeat any basic tests. They kind of just continue with treatment. So I'm usually the one that wants fresh hormone results, fresh ultrasounds, fresh spermiogram, and all of that.
Of course,
So
yes.
Yeah. Regarding lifestyle and supplements, diet, I try to not go in details of recommending something very specific to someone because I'm not a dietitian.
Mm-hmm.
I do recommend a Mediterranean diet because it's still the best. It's still the best in all of studies, in all of the, let's say, results we see. It's the Mediterranean diet still. I never recommend women to exclude certain groups. Like when you hear some women say like, oh, I'm cutting gluten because I read that this helps, I don't
Yeah,
know,
yeah, yeah, yeah.
or I've stopped eating dairy because I heard that this is bad for endometriosis or whatever.
Mm-hmm.
I don't believe in that. Usually there is no basis. Usually it's just like a general idea. So I never recommend that. But if a woman has tried to, let's say, stop eating gluten and has felt better, then of course, why not? She can continue with the diet. It's not hurting her, but it's not something that will just magically help. So that's
Yeah,
important.
yeah.
Yeah.
And tell us when you are done with your first consultation. Of course, then is next step is obviously a clinic.
Yes.
So, what are maybe the most common question? Let's say until we come to that main question that we need to answer. Most
Yeah.
common questions that women ask you. Example, what comes first to your mind?
So you're asking about what they want to know regarding the treatment or the clinic
Yes,
itself?
anything. That most common question in, yeah, let's say, in relation to treatment. Yeah.
Well, they usually just want to understand how it's gonna look like, especially if it's a, let's say, a couple or patients that are coming from Slovenia and going to Czech Republic or abroad.
Yeah, yeah.
Uh, they are very worried, not necessarily about the language and communication, because Slovenians are very good with English, but they are still afraid and not understanding medical terminology. They are afraid that they won't be able to explain something, or that is an
Yeah.
issue. But more than that, they want the logistics. Like, when do I do this? When do I do that? Do I need to be, let's say, abroad for a month, two
Mm-hmm.
weeks, one day? They need to understand how it's gonna look like.
Yeah.
Uh, they
Okay,
really
can you
want.
tell us? Tell
Yeah.
us briefly how one cycle look like if we want to go to Czech Republic, let's say.
So if you are going with your own egg cells and own sperm cells or donated sperm cells, then it's usually, let's say, approximately 14 days in total. You can start the stimulation in the country where you live in, and then you can have maybe the first ultrasound still with your doctor there,
Mm-hmm.
but the second ultrasound must be at the clinic where you're treated at, because they need to know exactly how to time the trigger shot and egg retrieval. So, but let's say in general, it's like maybe 14 days, depending on the protocol.
Mm-hmm.
Um, People that decide to travel to, let's say, Czech Republic and stay there, they usually stay for approximately 7 to 10 days, let's say,
Mm-hmm.
because they don't want to drive there and back. And so
Yeah.
maybe let's say 7 to 10 days. When there is egg donation or even embryo donation, which is even more simple, then the couple has only 2 visits. So the first one is when the partner comes to give a sperm sample for the fertilization. The second one is already transfer of the first embryo. So only these 2 visits. With embryo donation, only 1 visit, so only the transfer. So it's
Mm-hmm.
logistically actually very simple, but still, people are worried about traveling and all of that. So they still want to know the specifics. And there is still a factor of, even if you use donor for, let's say, X,
Yeah.
you're still waiting to find out the date of the egg retrieval, and you're still a bit nervous and,
Yes.
on the go. So it's still a problem for people to kind of juggle work and treatment and all of that. So you kind of need to help them with that. Yeah.
Yes. So you mentioned retrieval days. Let's go back to that also. You said that there was one time, the third day, it was retrieval, right? So can you please clarify for me, and I'm sure for everybody else, what is the difference between retrieval embryo back to day 3 or day 5?
Yeah. So there was this idea, let's say in the previous, I'm gonna say decades because it's quite a long time where we know it's better to transfer day 5 embryos, and this is
Mm-hmm.
the standard across the world now. So
Yeah.
we know that day 5 embryos have a better chance, they are better developed, and most importantly, embryologists can grade them much more efficiently, which means that when they examine them under the microscope, they can know if this embryo has good or not so good potential. It's not it's not like, let's say, an exact science, because the grade doesn't necessarily mean the embryo will or won't
Yeah.
succeed,
Mm-hmm.
but it is some kind of, let's say, idea of what we can expect. So if an embryo is really nice, really high grade, then we are optimistic. We think that this has a good chance of implanting. If
Yeah.
it's very poor, if it's developed very slowly, if it's not looking well, then we kind of expect it to not maybe work.
Mm-hmm.
When you are doing transfers on day 3, you are transferring blindly, shall we say. You are transferring an embryo that maybe looks good, but would not survive till day 5 or 6. So that's my issue, where clinics sometimes rush. They're afraid of losing embryos till day 5. So they just do a transfer on day 3 and hope that it's going to magically work, right? So
Yeah.
some embryologists were under the idea that when you transfer on day 3 and an embryo is not looking that well, or there is more, let's say 1 or 2 embryos, and you're afraid of losing them, you are supposedly transferring them to a more natural environment and you're helping them
Yeah.
somehow.
Mm-hmm.
But I think this was, let's say, not confirmed in any kind of studies. And I also don't agree with this, because a day 3 embryo would be still in the fallopian tube traveling towards the uterus. So, uterus is not the natural environment for a day 3 embryo. That doesn't mean that it can't succeed. Of course, it can, but it's not a good idea to do it. It's always better to wait until day 5, and then you can get a clearer picture of what you can actually expect.
Thank you so much for this explanation, because in my personal experience, all the transfers that I had so
Yeah.
far, even including 2 times with egg donation with the frozen eggs,
Yeah.
cells,
Yeah.
both times and previous times, they were returned to me day 3.
Yeah.
So do you think, not always, but in most of the cases, that this is just giving the false hope to couples?
That's hard to say, because, of course, if you're transferring on day 3 and the embryo is actually good, let's say high quality, and also maybe it has the potential of succeeding until day 5, then
Mm-hmm.
of course, if you transfer it on day 3, it's also going to succeed. It's not going to be a problem, right?
Yeah.
But it is maybe a false hope if you try to do a transfer just because, let's do it. Let's do it to make it happen, because we're very afraid that on day 5 we just won't have anything to transfer. Then yes, it is giving a false hope, because if you were to wait until day 5, you just wouldn't have any embryos, right?
Yes.
It can be a problem.
Yeah, to me personally, I'm always saying, for me, it would be more fair if doctors told me, hey, it's not the situation the best. We cannot
Yes.
promise that they will survive until day 5, but let's try. But not,
Yes.
giving me like what happened. They were giving me hope. They look good. They look great.
Yes.
La la la. And then nothing.
Negative. Yeah.
Yeah, negative. Okay, let's say everything is it's done. We are waiting for this 2 weeks, famous 2 weeks. Yes.
Yeah. Yeah.
And then, of course, we find out that our procedure did not succeed. Let's try to answer that famous question and
Why?
question that I asked at the beginning of our conversation. Why?
Well, there are a couple of main answers to this question. We don't have that much room to discuss, even though, of course, we can never be 100%, at any of these claims.
Yeah.
Most important is to know that in probably over 80% of cases where the woman doesn't get pregnant or has repeated implantation failures, it's due to the embryo quality. So this is more than 80% is the embryo's fault, if we can say it like that. And this is due to the fact that even if you are transferring embryos that are supposedly high quality, let's say they have a good grade, we still do not know anything about their genetic composition, their chromosomal, let's say, abnormality or normality, right? We don't know that factor. And I always hear patients say, there must be something wrong with me because the embryos were good. Well, how do
Yeah.
you know they were good? Well, the doctor said they're nice. Okay.
Exactly.
But that doesn't mean that they actually have the ability to become a baby. That's a completely different story. An embryo can look really nice under a microscope. It can be like, graded the best they ever saw, but still, there is a possibility that it doesn't have the strength, the metabolic strength, to continue with the process of implementation, or there is something going on genetically that stops the development. And this is the issue we have even with PGTA, so with the genetic testing of embryos, because with PGTA came the idea that when you do this testing, then you're transferring either normal or abnormal embryos. But that's not actually true, because when you're testing with PGTA, you take a couple of cells. These cells are from the part that's gonna form the placenta, not the baby, the placenta.
Okay.
So it's a possibility that maybe in the placental tissue, there are a few cells that are problematic, or let's say more than few cells that are problematic. But this is the placenta, still not the baby. And you can grade the embryo as being aneuploid or mosaic or some kind of problematic chromosomal structure, but the baby would be normal. And this is the finding of many, many studies now, which is a problem for ESHRE. ESHRE is kind of, let's say, straying away from PGTA. It's not recommending PGTA because when couples decided to still transfer embryos that were problematic, healthy babies were born. So this is why ESHRE is staying away from PGTA or just not recommending it, because we're actually not sure what does it tell us. Yeah, we know it found something, so the testing can find something, but it still doesn't necessarily mean that this embryo is bad and this embryo cannot form a healthy child, or this one, yes, this one will help. So PGTA was, let's say, confirmed as a possibility to help couples achieve pregnancy earlier. Maybe it can shorten the time to get to the pregnancy, but not by a lot, because you are maybe doing another selection and you maybe are, let's say, disqualifying embryos that are highly problematic. So kind of, but still, it's not actually recommended to do it for all or to just generally use it. I know that in America, it's very, very popular, very popular.
Yeah.
Almost all of the couples do it, especially women over 40.
But
All of
in
the
here also in Dubai, I know that everybody does that, and it's honestly, I'm not sure how is the pricing in Czech Republic, but here it's like
it's
astronomical
expensive.
price. Yeah,
It's
yeah,
expensive. All genetic testing is highly expensive, so it must be, let's say, recommended to patients that can actually have a benefit from it. So like I have had probably over 200 couples now, let's say in the clinic where I work with. I have 2 couples that I advise to use PGTA.
okay,
So I don't advise it. We as a clinic don't push it because we understand that it's not like a magical thing that you offer and the couple gets pregnant. So it's very, very specific to who we recommend it. In egg donation, it is not recommended at all
yeah,
because the high quality of egg cells, along with, let's say, a good quality of sperms,
yeah,
we are expecting a good development of embryos.
I understand.
Unless there is something tragic and let's say all of the embryos fail or something goes wrong, then we might advise, let's say, the men to do a karyotype testing and maybe yes, let's test the embryos, but it has to be something very problematic to do it. So yeah, so this was my answer to the main reason that women don't get pregnant are the embryos themselves. This is the main reason. The other reasons can be maybe some kind of uterine abnormalities due to adenomyosis, maybe endometriosis, but it has to be quite severe to be a contraindication for pregnancy. Let's say it can be also some kind of chronic endometritis that goes unnoticed and wreaks havoc in the uterus, maybe. And of course, any and all serious medical conditions with the woman herself. So, let's say lupus or other autoimmune diseases or something that's like severely impacting her ability to get pregnant. But that is very, very rare. Like in general, women just tend to not get pregnant because of the embryos themselves. Yes, sometimes it can be on the side of the body or the woman herself, but that's a minority of the cases. So it's very important for women to not try to find an issue within themselves, because I know that women are, trying to find, why am I not getting pregnant? What
Yeah,
am I not doing correctly? Oh,
yes,
maybe I did this wrong. Next time I will try to do it like that. Oh, but I did have a lot of stress. I didn't drink this. I didn't take my vitamins, and it's highly problematic because it puts the blame on the woman where
true.
it shouldn't be there.
Yeah.
Usually it should be there.
You mentioned adenomyosis. Let me just have a cross question on this. Is it possible that a woman can get pregnant with adenomyosis?
Absolutely, of course, yes. Adenomyosis is, let's say, highly problematic for conceiving and, well, even more than that, maybe delivering. It can be an issue where the uterus is expanding, and maybe it can be a problem then. But no, if a woman has a diagnosis of endometriosis and adenomyosis, because they are usually friends or
Yeah.
sisters or cousins,
Enemies are our enemies, yeah?
but yes, huge enemies for women. No, that doesn't automatically mean that the woman can get pregnant. It usually has to be a severe form of adenomyosis where we start to doubt the possibility of the woman to get pregnant. And yes, if there is a severe issue, then sometimes maybe the only option is surrogacy. So that can be the solution for hugely severe cases, but that is
R-
not so common. It's quite rare to have this kind of issues. But yeah, there are some kind of protocols that can help women with adenomyosis. So it's like a down regulation method where the woman can take like it's called GnRH agonists. It can be a depot shot or a daily shot, where basically the woman goes in a menopause-like state, and it brings the hormones down to a level where the adenomyosis starts to shrink a bit. It doesn't go away magically, unfortunately, but it goes down enough that we can then plan the transfer quickly after the treatment.
Yeah.
But it has to be quite a severe case, so the doctor decides to do a protocol like this.
Okay, it's clear. In your experience, is there any tests that you would say that they are not really, I can say, helpful, but they are still advised for couples to do them?
Yes, of course. I mean, there are a lot of tests that are offered, or treatments or protocols that have no real let's say it's not confirmed that they can actually help. So that's a huge problem. ESHRE has, it's called like I'm looking for the English word. It's like a green light, red light, and yellow light, where they put this kind of information in the red, where it doesn't benefit the couple at all.
Kind of grading.
Yes, the yellow is maybe, we're not sure, and the green is yes, it can help. So when you look at, let's say, the recommendations from ESHRE on treatments, examinations, procedures, you will get a tiny amount of recommendations that are green lighted. So they are actually acceptable, they think that they can help, and they can be recommended. Then you will see a huge amount of
yellow.
that are in yellow of, we're not sure if this actually does anything. And then you will see even a larger amount of treatments, procedures that are, let's say, red, which means that we actually don't see any benefits from them, but they are still used. And this is a huge problem because the doctors know this, the embryologists know this, so the specialists are aware of all of these procedures being problematic.
Useless.
Maybe even useless, but the patients try to demand them still. They want something extra, they want something to be done. They read something, their, let's say, friends had this or whatever.
Yeah.
So they still offer it, or some even recommend it. So it's very problematic because we don't have enough information about certain tests and examinations, but patients still want them, so doctors can still recommend them. It is, however, important to know that usually we're not doing any harm. We're not, affecting the results in a negative way, but still the patient should know that this probably might not impact their chances for success. So I'm quite, let's say, apprehensive of the ELA-EMA-ELIS tests, so the receptivity test. The EMA and ELIS are not that problematic because they're actually looking at the, let's say, chronic endometritis or pathological, let's say, bacteria or anything like that. So that can be useful because the woman can actually be treated for that and can have a better chance of getting pregnant. But with the endometrial receptivity test, it has been quite an issue between, let's say, the scientific minds to try to, let's see if it changes anything. Doctors usually recommend it because they are not sure whether to plan the transfer classically, so let's say the classic 5 days of progesterone prior to the transfer. They can advise it when a woman has had many failed transfers and they're actually wondering why. So they don't really understand why she failed.
Can you please
But
just quickly tell us what is that ERA test? What is that, so we
it's
understand?
basically trying to find out the best window of implementation for the embryo when the endometrial receptivity is at its highest. So when you take the biopsy and you test it, then you can see if the woman needs either more or less hours of progesterone to
Okay.
be prepared as it can be to receive the embryo. So you're trying to
Okay.
find out, does the woman need more time before the transfer or less time before the transfer?
So
So when
finding
you
the
get-
right window for implantation, basically.
Yes. So when you get the result, it can be like 126 hours or 120 hours or whatever. And the clinic will then decide when the women will start with progesterone exactly. So you might get the result that you need to start at 5 in the morning with the first progesterone pill. That's
Wow.
your result. Another one could be like a day after that. So even like a shorter period of progesterone supplementation. So it's mostly trying to help the doctors determine the best time to start progesterone and then plan the transfer. That's in general what we're doing with the test.
Yeah, actually, I was advised to do that. So, you know, I was reading, of course, Googling about it immediately. So, from one side, I read some medical researches which don't confirm actually that this will help. But in any case, they're saying that if you measure that in 3 months in a row, there might be different responses. But
Yep.
then on the other side, as every woman, I go to forums, of course, and then I read all the forums. And then again, there are experiences of women who have done that kind of test, and they are
And then
like,
what-
yeah, for me it helped, it worked, you know, so
Yeah.
it's like 50-50 basically.
It's an examination which is not going to hurt you in any way. So it's not gonna, let's say, negatively impact your chances to get pregnant. Maybe it will increase it. We don't know. But it's not something that you should be afraid of doing it or adhering to the results of the test.
Yeah.
Because it can be positive. It's just
Yeah.
not something that I would recommend to just anyone. Also because it's quite an expensive test and it should be cheaper for what we are trying to find out. But you know,
Yeah.
it's to the labs that are actually doing the testing, so we can't really impact that.
I will do it. So let's see. I will
And
do
you
it.
will let us know. And
Yes,
you will
I will let you know for sure.
Yeah.
Okay, we have to wrap up our conversation. I have 3 more questions. First
Sure.
question, if you can give us like for men, let's say the most important test in your opinion, and for women, let's say 3 most important tests that are recommended for us to do.
Well, for men, we're quite limited on what we can actually do. Of course, spermiogram is the base. I mean, we can't do anything without the spermiogram. We would be shooting blindly and
Yeah.
wouldn't do anything about it. Now, specialized tests such as DNA fragmentation or, let's say, tests that try to determine the life or death of the sperm cells, so which are alive and which are actually not alive.
Yeah.
These are specialized tests that maybe they can be useful in some cases, but usually not as many times as we would like. So when you do DNA fragmentation, you try to see if the man has a higher percentage of DNA fragmentation within the sperm cells themselves. So DNA fragmentation just means that the DNA is broken. It can be broken on one strand or on both strands. You're trying to determine if the sperm cells are carrying with themselves issues within the DNA, which can then cause, let's say, miscarriages or an
Okay.
issue with the developing embryos or something like that, right? But we can rarely impact the DNA fragmentation. So it means that even if a couple gets the result back that it's very high, so it's like 70%, and you're like, oh my God, the men cannot impact it in any way. Yes, they can try to, be more healthy and, take supplementation,
Yeah.
but we don't really know if it's going to affect it or not. We can do our best with the sperm selection.
Mm-hmm.
In cases, the microfertile chips are the best. Like the type of selection is the best, the chips, and they usually cut down on the fragmentation from 50 to 80%. So it means that when they do the selection in the lab, they will choose the best ones that have a much lower chance of DNA fragmentation. So this is
Mm-hmm.
the solution, let's say.
Yeah.
Other than that, if there is like a huge problem with the sperm quality, then a complete checkup with a urologist. So not with the gynecologist,
Okay.
but urologist. That means like maybe even taking some samples from the urethra, so like a swab, to find out if there is some kind of E. coli infection, to do an ultrasound of the testicles, to find out more about the men and the reason behind the poor spermiogram. So that would be
Okay.
like for women. Well, of course, the basics are hormones, ultrasounds. That's great, but if there are special issues, maybe with pregnancy loss, or maybe with her not getting pregnant at all, then in these cases, I usually recommend, our clinic recommends, we go for certain immunological tests.
Okay.
Is also trying to test for, of course, sexual transmitted diseases, some, let's say, infectious diseases in the childhood, maybe specific antibodies. This is a bit more complicated to try and discuss now. And hereditary thrombophilias. That means if there is any issues with blood clotting. So if a woman has a higher chance of blood clots, so these are like factor 5 Leiden or factor 2, if she is positive here, then we know that she needs a specialized protocol to try and keep the pregnancy. So that means maybe heparin injections or aspirin or a combination of both, and to be just more vigilant during her pregnancy. And she might need this therapy throughout her pregnancy to keep
Yeah.
it to come to term. Uh, but that's almost it, unless she never had any kind of hysteroscopy, laparoscopy, anything like that, then this would be the methods that I would choose. If she never had any kind of, let's say, interventions or anything like that, then of course the first one would be hysteroscopy to see
Mm-hmm.
what goes on in the uterus, to try
Yeah.
and decide, is there something there that's not right?
Yeah.
But when you hear all these different other advices on what to get tested, then I'm not that convinced that they can actually change anything. So that would be my recommendation.
Okay, but I'm sure during the consultation with the couples, you can give more specific.
Specialized. Yeah,
Yes.
yeah, yeah,
Hmm.
yeah.
Okay, one last question. What would you say or recommend to all the couples which are struggling to become a parents? What is your message for them, considering your personal experience and your professional experience working with so many couples up until now?
This might be, well, not misunderstood, but I always say that perseverance is key. So continuing with treatment, not giving up, because in my experience, patients that continue with treatment and try everything that's possible and available to them usually end up with a child. The most problematic part of IVF is the emotional and psychological toll it takes on a
Yes.
person and on the couple. And if you stop treatment before you could actually see if it does have a potential to succeed, so if you stop too early, then you basically robbed yourself of that chance, right? So I would just say, please try and try for as long as you possibly can. And that does mean that you have to kind of maybe find some better psychological support, maybe even couples therapy or let's say counseling or whatever. But try to continue for as long as you know there is a chance and the doctors are also telling you that there is a chance, then you should continue. Because I see too many cases of where the couple maybe sabotages itself. You know, they just go like, okay, we will try one more time. And if this doesn't help, then we're stopping with treatment.
Yeah.
But it doesn't mean it's not gonna work. It just means they're like at a point where they don't see why they should even continue, right?
Yeah.
And this goes with egg donation especially, because when they come to this point, they're like, okay, we are willing to try egg donation, but they expect it's gonna work right away. And if it doesn't, then they say, okay, so even this is not working for us, we're stopping, we're gonna be without a child, or maybe we
Yeah.
will adopt, and they just discontinue. Even with egg donation, which is a highly, highly effective method of treatment, you still might need multiple cycles to achieve a healthy pregnancy. So this is very important for someone that's deciding to go abroad for, let's say, egg donation. This doesn't mean that you will go one time, have the transfer, and go home with the baby. It can happen, it does happen, but usually you have to prepare yourself for multiple transfers or even multiple cycles. So just keep going, don't stop.
That's what I'm always telling to myself and to all the listeners here on my podcast, to be honest.
That's
That's
the most important.
That's amazing. Thank you very much, Maja. And one last question, and I'm sure that there will be lots of women, couples who would like to have a consultation with you, considering that you are so open and direct and straightforward. And I know personally many women through the podcast who had so many failed cycles and who are really, I cannot say desperate, it's not the right word, but
Struggling.
they need to hear some other opinion and maybe to find that light at the end of the tunnel. Maybe you give them different perspective. So what is the easiest way how women can get in touch with you?
I mean, if they follow you on Instagram or if, they're on social media, they can find me basically on all of the social media that's, let's say, most popular. So Instagram, Facebook, it's just Mami Maja. So it's very simple. They don't have to try and type my name and surname. They can send me a message there and try to explain why they want to come in contact with me or what specifically they need. And then we can do everything via email or let's say like Teams consultation or whatever. So that would be the easiest. Of course, I could give you my email, but certain people are afraid of trying to or something like that. So maybe social media. So like Facebook, Instagram. Yeah.
So don't worry about that, ladies. There will be Maja's Instagram in the description of this video. So feel free to drop her a line, ask whatever you need to ask. If you need consultation, of course, you can get in touch with Maja, and I'm sure that she will give you some guidance and help you on what you should do next. Thank you. Thank you for this conversation, Maja. To be honest, I personally learned a lot, and this part when you were talking about day 3, day 5 egg retrieval, for me it was the most interesting, to be honest. And thank you for sharing with all of us this really valuable information. And I hope it was pleasant for you as much as it was pleasant for us to listen all of this.
Yeah, thank you. If they will be interested, we will do part 2, maybe a specific topic. Maybe there is something that they feel like it's not discussed enough or anything like that. Then we can do another one, and hopefully we will. Yeah.
we can do. I can do the research through my channel and see what women want to know. So we make we continue this conversation. Thank you again, Maja. And you ladies, of course, as usual, follow me on all social media. And you can check my website, thepoweroftruestories.com. If you would like maybe to take a part in the conversation or to tell your story, you can contact me through Instagram as well. You can drop me an email. So it's very easy to get in touch with me, but I promise you, after you tell your story, you will feel so much better. So I invite you to write me an email or drop me a message on Instagram. I hope you enjoyed this episode. I hope you got some valuable information. And I'll see you soon. Ciao.